Good afternoon. Welcome to today's webinar entitled Managing Neurointervention During COVID-19, a roundtable discussion and lessons learned from 3 COVID-19 hotspots in the country. Our 3 speakers today are Dr. Melanie Walker, Dr. Gary Duckwiler, and Dr. Maxsim Shapiro. Your webinar will begin shortly. If you are disconnected from the webinar, you can re-enter the program at any time by following the instructions that have been provided to you. If you are still having difficulty connecting to the webinar, you may call our technical support hotline at 1-877-992-7225. Again, that phone number is 1-877-992-7225. As a reminder, this course is sponsored by Medtronic Neurovascular, and as such, no off-label discussions are permitted. If you have any questions pertaining to off-label use, please direct them to rf.nvoma@medtronic.com. Now at this time, I would like to introduce our speakers for today's webinar. Our first presenter is Dr. Gary Duckwiler. Dr. Duckwiler is a professor of radiology at the University of California, Los Angeles, the section chief and clinical director of the Division of Interventional Neuroradiology at UCLA. Our second presenter is Dr. Maxsim Shapiro. Dr. Shapiro is a neurointerventional radiologist at NYU Langone Medical Center in New York City, as well as a clinical associate professor of neurology and radiology at NYU. Our third presenter is Dr. Melanie Walker. Dr. Walker is a clinical professor of neurology surgery at the University of Washington School of Medicine. Dr. Walker has extensive experience in global health and development, serving previously in various roles at the Bill and Melinda Gates Foundation, World Health Organization, and World Bank. We'll get started with Dr. Duckwiler. The floor is yours.
Okay, thank you very much, and thank you, Medtronic, for putting this on, and thank you to my fellow speakers at this session and everybody who's joining. And I hope that everybody on the call is doing well and hanging in there during this difficult time. So we will give some short talks about how we are handling the crisis at each of our institutions, and then we'll have plenty of time for questions. So please submit your questions, and we will be able to get to many of those at the end of this session. So by way of disclosures, none are relevant. Well, I guess it's relevant. Proctor Pipeline Medtronic. Okay, so first and foremost, we have to look at the processes, how it's affecting, and how we're operating. So try to be as short as possible, but when we're talking about acute stroke in this particular time, I wanted to go through how and what we're dealing with. First off is our CT MR protocols. I work at 2 institutions, UCLA and a large community hospital, Long Beach Memorial Medical Center. At UCLA, we're a MR first institution, but the first thing is, just because of the complexity of the space in the room, we have switched to being a CT first imaging for acute stroke due to the fact that the MR room is far more complicated to clean. And the cleaning of the room can take the MR down for quite a bit of time, much longer than the CT room. So utilization of resources and what can be used and what the turnover are very important factors when planning and reacting to the current situation. We have 4 scanners in our UCLA hospital. One is very close to the emergency room. We call that the ER scanner. There are 2 others on the first floor in the core, and then 1 on the second floor, which is the interventional CT scan. So luckily, we have enough testing now that all the inpatients and all the ER patients are tested, and that means that if inpatient has come in for something else and they've gotten their test and something comes up, such as a stroke comes up later on their admission, normally we would know the results of that. ER patients, obviously for emergencies, we don't know the status for at least 4 hours, but our rapid testing gives us results in about 3 to 4 hours. So when I said we are MR first, we're now CT first, and we use the ER CT first. What we have to do if we have a positive patient, we wait 20 minutes after that patient is scanned to let any droplets fall out of the air, do cleaning, and that takes about 20 minutes, and we shut down the room for an hour afterwards. Always wear level 1 PPE, or if it's a positive patient, unknown patient, and a level 2 PPE. So that means that room, that scanner is down for at least an hour or more. MRs are down for even longer, and they are a more precious commodity. So we only use MRs selectively in acute stroke. We do have some considerations for how these patients travel through the hospital. Unfortunately, we don't have that many options, but the one thing you have to consider is how you get to the scanners. And in MRI, we have 3 entrances per se, and we select one to use to minimize the amount of cross-contamination. This 1 hour waiting time, it's not entirely clear what that's based upon, but we did do a study, or at least we have data on the air room exchange per hour, ACH it's called. So this is the number of times the entire air volume of the room is turned over. And you can see for our CT scanners, at least 2 of them, there are about 20 air room exchanges per hour. The 4 interventional suites, the neuro rooms are slightly bigger because they're biplane, fewer, about 15, and the interventional rooms, monoplane rooms, are about 20. So when we wait an hour, we get pretty good scrubbing of the air, even though none of these rooms are negative pressure rooms. What are our guidelines for patients who are positive or negative or uncertain? For every stroke that we see, we're never going, unless it's an inpatient who has already had testing, we're really not going to know what their COVID status is. So we treat all of those as if they were positive. And so level 2 PPE is worn by all staff in the duration of the case. Once the patient is left, again, just like the CT scanner, we don't enter the room for 20 minutes unless we're wearing PPE, and then we call for cleaning and go forward. We have, for known positive patients, both for peripheral interventional, for all interventional cases, either body or head, try to do those in one room. So we have a quote-unquote COVID room, but sometimes we just don't know and have to find out later. Luckily, with our rapid testing, we can find out later on if that patient was positive or not, and that can alter our processes in terms of handling the room later. For patients who are asymptomatic but don't necessarily have a test, we usually use level 1 or standard PPE. And the one thing is that during any aerosolizing procedure, such as intubation, generally wear level 2 personal protective equipment. Whether or not to do general anesthesia is a big issue, and I'm sure Dr. Shapiro and Dr. Walker will address this too. This is our flow sheet. But we do, at UCLA, mostly sedation only or no sedation at all, preferring that over general anesthesia. We will do selective general anesthesia when necessary. We haven't changed that policy at this point, but that is a major concern, and it's a major concern for our anesthesiologists who join us in the case. So I would say some are biased towards providing general anesthesia as soon as possible to limit the amount of spread. But there are pros and cons to general versus sedation, and I think that we can have a much longer discussion between the 3 of us what's preferred. For us, our angio rooms are not negative pressure rooms. So doing general anesthesia in those rooms means that it's definitely contaminated if you do general anesthesia in there. So if at all possible, we avoid it. We do have negative pressure rooms in the ER, but oftentimes those negative pressure rooms are occupied. And so there's a problem if a stroke patient comes in. Do you intubate them in the emergency room in a non-negative pressure room? Can you get a negative pressure room? Or do you avoid, are you spreading things in the ER or the angio suite? It's a difficult decision sometimes. Also, for our anesthesiologists, concerns for general anesthesia in the emergency room, and that's not their general position, so they don't have their medications, they don't have the anesthesia machine. Is that patient going to have more difficulty with hemodynamics and sedation, et cetera, et cetera? So I know the other speakers will talk on this, so I will hold off further discussion until we get to that. But the most important thing is once that patient is intubated using a filter, so the risk of any escape of virus is minimized. Inline suction, so that you're not having to risk aerosolization by needing suction. And when the patient is avoiding coughing, so a lot of generous use of neuromuscular blockade. And if there is required to any changeover, say the anesthesia machine or anything is necessary, really only do that at the end expiratory phase so that there's no air in the lungs, so minimal chance for exposure for everybody else. At the other institution I work at, Long Beach, they do use these barriers, and they do video-based intubation. It's another consideration for your anesthesiologist in protecting staff. A minute on our materials. Obviously, depending on where you are, you may or may not be lucky enough to have sufficient materials. We have a particular issue with eyewear. So we are rewashing our eyewear protection. We are reusing our N95s. There are a couple methods of sterilizing N95s. At UCLA, we're using UV. This is called the University of Nebraska protocol. This is for people who are using them on a daily basis or frequent basis, so mostly on the nursing floors. And you send your own personal mask, labeling it such. It goes to UV sterilization, comes back for reuse, so long as it's not grossly soiled. There are other methods of sterilization. The use of hydrogen peroxide vapor is used, and the UV gives you maybe 5 uses. So long as the mask is intact, sterilizers give you about 3 uses. Since our staff in IR rotate in terms of call, they're not on a daily basis, recurring, our N95s go through a different process. One of the most important things, we have social distancing, right? So we're trying to do that as well with our staff and faculty. So we had to reorganize our personnel to minimize interactions between those personnel. So we have the body teams and the neuro teams, and we have 2 neuro teams, which involve 2 physicians per team and about 3 nurses, 3 techs per team. So that, team 1 is on 12 hours and then team 2 is on 12 hours. This minimizes any contact between those groups, and if one group gets an infection, then there is another group that is available to take over. This was not as easy as it sounds because there is a union at UCLA for techs and nurses, and the regulations are such that work schedules have to be approved, and the minimum review time for that was 15 to 45 days. And so we worked out this schedule of 12-hour shifts, and in a 5-day work week, we had to alternate between these teams. One team doing 2 days primary and 3 days call, and the next week then doing 3 days primary and 2 days call. And that drove our organization of these separate pods or separate teams for all neurointerventional calls. We call it the stroke team rotation. So again, a way to minimize spread, and if somebody does get infected, then minimize the spread or potential contamination of other members of the team. We are doing outpatients, but only if they're urgent and cannot be delayed 30 days. The process whereby we do urgent outpatients is we need approval by chief of service, at least for neuro cases, that's me. We only schedule it on the physician's team day, so again, to make sure it works in the schedule and not having a physician work with the other team. And right now, our testing capability is such that we can get testing 48 hours before, or we can get testing of all patients coming in for general anesthesia before the procedure. We typically do that 48 hours before. And if they're negative, they come into the standard procedures. But if they're positive, then we change the workflow, and they still, if they're positive, still need to be done. And they bypass the pretreatment unit. So they don't go through the normal admissions process. They go directly to the angio suite and are recovered in the angio suite or go directly to the ICU. So we do have a process whereby positive patients can be done if they're urgent and they're outpatient. But first step first is we try to postpone those patients if at all possible. Restarting elective cases, we're at a phase where we are in process of those discussions and putting together working documents on how to do that and whether we do it in a staged fashion, who gets prioritized, as we have seemed to have reached a plateau, at least at UCLA, in terms of our ongoing cases. Just to remember for infection, you know, when you're in the room, you're covered pretty well. Most important part is when you take off stuff, that's when you're going to get exposed, and you have to have very good processes for that, and everybody has to follow those processes. If there's exposure, then staff goes out, and it's really when you're exposed to an aerosolizing procedure without wearing level 2 PPE, and for at least at UCLA, the policy is you're out for 7 days, and then if you don't develop symptoms, you can return to work. We have a symptom tracking system where you log in and record your temperature, et cetera, any symptoms. Any other exposure, you're still able to come to work so long as you don't have any of those symptoms. Things change daily, and this is the slide I had previously about PPE. Now with additional resources, we've gone to universal PPE, so you come into the hospital, you get your temperature checked, they ask you for symptoms, and they give you PPE when you come to the hospital. With that, I will stop and hand it off to Maxsim Shapiro from New York City at NYU Langone Health. Max, I'll hand it over to you.
Thank you. Thank you, Gary. And thanks everybody else for joining as well. I see we just have over 150 people now, right? So thanks so much. And again, as Gary had mentioned, I think we just want to show some slides and generate some topics for further discussion, but we want to leave plenty of time for you to ask your questions. I see questions are starting to pop up, so that's great. So I think some of it's going to be redundant, of course, but in terms of the general things that I want to address, I just want to I think it's been, again, these slides are just about a week old, and as you know, things change very quickly. Hopefully, we hope that we've seen kind of the peak of, as you have on the West Coast, we're hopefully starting to see some drop in rate of admissions and so forth. So hopefully we've seen the worst, but hard to tell. A lot of what we've done already just had to do with coordination. And I'm sure for the places that might still see an increase in their cases, you've probably gone through this protocol already, but there's definitely no substitution for administrative coordination of how to handle this on so many levels. What Gary had mentioned, team structure, that's a big thing. We too have, as you have, we've tried to implement a kind of a team system, keeping one team forward for the call responsibilities and keeping another team back, at least a physician and a fellow, or depending on how your team operates. You know, places have bigger or smaller teams, but to have a backup team is essential, as of course many of us have limited number of providers for the critical services that we do. And keeping a team that's hopefully going to be healthy is very important. In terms of continuity of essential services, I mean, the more this has kind of gone on, the more we think of it as a two-tier approach in terms of what we can do for patients with COVID that are having issues, ischemic or hemorrhagic, or what we can do for patients that don't have COVID. And it's extremely essential, especially in a place that has a big outbreak, that we continue to offer our services. As you know, there's a lot of stuff is now coming out in the media in terms of collateral damage from this, reduced access to stroke services, reduced number of STEMIs, strokes, patients, for whatever reason, that are not coming into the system, either because they don't want to go to the hospital, afraid of exposure and so forth. So that needs to be teased out. But for sure, in our institution, we've seen a drop in terms of our overall COVID negative stroke volume and an increase at the same time in terms of the COVID positive issues that we'll get into in a little bit. But underlying all of this, I think, from our perspective, it's absolutely essential that we keep our services going. We have a service that is obviously critical, and there's no substitution for that. And that works both. We cover two hospitals. We cover NYU University Hospital and also the Bellevue Hospital, which is part of the city hospital, part of the Health and Hospitals Corporation, which is a large city hospital system that has seen also an unprecedented number of COVID patients come in. And so maintaining services in both, as thankfully we've been able to do, has been critical. Coordination with other services, neurology, neurosurgery, radiology, from whatever part you come from, is of course essential, as well as tech support, anesthesia, and so forth. All of that, I think, maybe goes without saying, but if you're, depending on where you are in the crisis, if you haven't seen a rise yet, now would be the time to kind of get in there, coordinate with administration, because oftentimes the administration obviously needs to be on board in terms of what it takes to keep the service going, what are the resources that we need, perhaps the bare minimum resources that we need, but we still need some access to this or that resource, some kind of ICU capability for some of our hemorrhagic patients and ischemic patients as well, and also some flexibility. As you know, there's been no shortage of changes in protocol, institutional and national, in terms of what we do. Just to give some examples, like where do TPA patients go, what kind of care they need, how often the neurovascular checks are administered, where do post-procedure patients go. All of these things are obviously a part of a bigger picture in the institution, but a discussion with administration for us and has been very productive, and I think that can be very good for other institutions. For crisis mode operation, again, I think is a lot of the stuff we should be discussing in questions. Generally, we've tried as much as possible to avoid changes to existing workflow. So, for example, we tend to do most of our ischemic strokes under general anesthesia. So in that sense, we have maintained that protocol. We have, we're blessed with having a pressure negative biplane suite, which is, most suites are not, but in our relatively new Kimmel Pavilion, we have one room that's pressure negative. So we've converted that to a pressure negative room, and that's where we do all of our confirmed COVIDs or COVID unknowns, which is pretty much most people that are coming off the street are going to be unknown at that time. And so we reserve our positive pressure room for people that are known to be COVID negative. I think we'll get into this resource utilization, resource availability a little bit later. I think these questions are going to come up, and they're going to be probably more addressed on an individual basis in the institution. The team structure, again, we've maintained kind of our team structure, but a lot of the, at least, as far as much as we as fellows and attendings have been affected by this, I just can't say enough about how much our nursing staff at both hospitals has been in the forefront of this. If you see what's going on the floors, who goes into the rooms, who's getting exposed, it's really the nursing staff it's just a tremendous number of heroes. And over a huge number, I think over half of our nurses have been reassigned to the floors. So all of that, and it's just not the nurses, the techs, the people that go up and they do the portables and whatever it is that needs to be done. And as I'm sure you know, for many people, a lot of them are paying the price for this. We've had people that are obviously turning positive, getting sick, in some cases quite sick. And so there's been a tremendous amount of sacrifice on the part of the entire team. And so maintaining that structure within that context, I think, is important. And flexibility is too. In terms of the guidelines, I don't want to spend too much time on the guidelines, but I think it's good especially for the leaders, to be familiar with the guidelines. Because you can use the guidelines, they can be used in terms of your discussion with administration, for example, what you might need or what the guidelines might advise could be quite useful. Clinical points, I think that's going to be, we'll leave that for a lot of the discussion. The unclear COVID status we've covered. I think things have been emerging. We can get into like the whole clinical situation of what we've seen generally at NYU, at Bellevue, and also within the larger New York City. We have seen for sure an increase in ischemic burden of COVID patients related, no doubt, to the hypercoagulability. And that's a whole big discussion about like how that comes about and what to do and how to address that. But that has manifested in both on the arterial side and on the venous side as well with venous thrombosis. And so we've certainly seen a shift from, again, from lower number of COVID negative patients reaching the ERs to an increase in COVID positive patients presenting with occlusive disease. Probably, I think depending on where you are located and depending on what center you're in and what your relationship is with the EMS, with other providers, I'm sure it's very important to be able to to spread the word through your system that if you are functioning, if you're able to take transfers, that you do that the EMS knows that you're available and that you're ready, willing, and able to treat. That I think is probably one of the most important things we can do is to stay really available, not just for the positive patients, but for the negative patients who unfortunately seems like there's been a drop in terms of their access to the health care that we can provide. For hemorrhagic disease, we have also seen, and that's coming out more and more, that there is a hemorrhagic component to COVID, both on presentation and also related to anticoagulation, of course, for the variety of ischemic issues, PEs, and so forth. But there's a hemorrhagic component to this, too, that we might get into a little bit later if there's interest. And, of course, the overall picture perspective, but I think, as much as we're a critical service, we're a relatively small part in a very big picture. And just in the past couple of weeks, our team has kind of been helping out with communication with the patients that have COVID that don't have any neurologic issues, but they're on various floors. And most systems, as I'm sure you know, visiting these patients by relatives is prohibited. So their loved ones can be in whatever state, and it's very hard to see them. They cannot be seen by relatives. Oftentimes, they're too sick to be able to, pick up a cell phone. And if they were to use it, the result might be difficult. They might be short of breath. They may not be able to speak very well. And so we do a lot of communication with the families. And as part of that, we've kind of been up there and seeing the general medical situation with the COVID spectrum patients. And there's no substitute for seeing that. And I certainly encourage everybody to learn the general medical kind of overview of what COVID is and what happens with that and what people are going through, because that has been extremely educational for us, and I think we're better neurointerventionists for that, and we're able to see ourselves as part of a bigger picture. So I think I can't emphasize that more, how important that is to understand the disease from a medical perspective. We're very much subspecialists, but in this kind of crisis, even if we're not directly involved in patient care for non-neurologic patients, to understand what as much as we can, what people are going through, I think is very essential. And finally, I'm just going to leave it in a little bit of humor in this. It's a very difficult time, and it's hard to, sometimes it's hard to find too much solace in anything, but we are, we see one of the things that I've tried to kind of talk to myself about is to try to see the glass as 1/10 full. We probably will get into it a little bit more, but as you might guess, a lot of the patients that have COVID that are presenting with occlusive disease with neurologic symptoms are presenting on the background of very, very serious systemic issues. Not everybody. There's a spectrum. There are patients with relatively mild respiratory symptoms that can have fairly profound presentations neurologically. But in general, if you look at the entire spectrum of what we've been exposed to so far, it's patients that are very, very sick overall that have, in addition to everything, a neurologic issue. And it's quite sobering to see that, we have to be ready to accept that our outcomes angiographically may be as good as ever, but clinically we have to be ready to see the glass as a little bit, not half full, but maybe 1/5 full, 1/10 full, and just take whatever win we can get. Because oftentimes, our wins are not what they used to be. But we hope, obviously, we continue. We're staying on, and I think the best Again, the most important service that we can provide is to be available. Is to be available for everybody for the life-saving things that we do. With that, I want to thank you for your attention. There'll be time for questions. We'll turn it over to Dr. Walker.
Thank you. I'm Melanie Walker. Thank you, everybody, for joining. And to my two colleagues online, I just want to say thanks for having me here with you. Dr. Shapiro almost trained me, and Dr. Duckwiler, of course, is a great role model for me and many of you. So it's just a privilege to be here, and thanks for taking the time. I am Melanie Walker. I live in Seattle, and I'm going to be talking today primarily about stroke. I'll talk about a couple of our other interventional issues, and at the end, happy to take any questions. I've been taking notes, and I'm going to serve as the question moderator as we get to the end. So just be sure and type your questions in, and we'll do our very best to hang out and answer all that we can. I work in the Department of Neurological Surgery and at our Applied Neurosciences Center here. I think my only disclosure is that I support Medtronic in an educational role. I want to point out, as my colleagues have, and for those of you that have joined early, this is all going to be a bunch of repeats, but for those of you that have joined a little late, some of this may be new. So I'm going to go ahead and just kind of give my whole presentation and not try to shorten it at all based on the words of my colleagues. Can't really do this alone. We always think that we can as proceduralists. You know, we're in the room by ourselves digging around in brains, but it really is a whole team. In our case, and in the case for many of you, it's the neurologist, the anesthesiologist, the infectious disease, ICU doctors, nursing. You don't want to forget about the administrative team, especially in COVID. A lot of these policies aren't just done by us, but they have to be relevant to the whole rest of the hospital too. So in COVID, more than ever, I think we have a great reminder that we are one big family and not really just our own team. I have some pictures of Seattle for those of you that have been here. You know, everywhere it's kind of shocking. I bet Dr. Shapiro has some crazy New York pictures about how empty, but I've never seen Pike Place. I've been here 20 years. I've never seen the market look like that. Nothing on the shelves, as you guys know, except for these crazy cotton gloves. If you look on the bottom right, I've never even heard of cotton gloves. Those shouldn't even be a thing. But today, in fact, I was driving home and there's more traffic out, so I think people are starting to be a little more brave, but we are still currently on lockdown, and I'm sure your city looks like ours as well. Sorry about the formatting. We're just using a little bit of a different system. I've included here kind of our OR procedures. I think my colleagues have mentioned that we're not doing any elective procedures, and we stopped doing elective procedures here at Harborview and at the University of Washington a couple weeks ago, as hard as that is, and defining what urgent and emergent and elective really means in the neurospace is tricky. At least for strokes, we know those are emergent, but I think it does come up quite regularly what is an emergency case, and I think each of you is going to have experience differently, but we can talk to some degree about that later. In terms of pre-testing our patients, I think my colleagues talked a little bit about this. When we know in advance, it's easier for us to be able to test patients. We try to do it 48 hours before a procedure, but some might argue if you can wait 48 hours, it's not an emergency procedure, right? But at the very least, we test patients upon arrival. We assume that all patients are COVID positive. It's kind of interesting. We don't take outside tests. Not that we don't, believe, but it's sort of trust but verify. Some patients have already had a test at the outside, and we certainly use that as guidance. But what if they'd had it a week ago? What if they've had it 20 minutes ago? We don't have results, blah, blah, blah. So we're just not sure. So they will get a test when they arrive. And as I said, most of our cases are emergent. How would they know 48 hours in advance? But you can see from our operating room boards what that's like. And so what have we learned so far from all of this? I'm just going to click through my slides here so that you guys don't get seizures watching me click. We sort of assume now that all patients are COVID positive until proven otherwise. Many of you probably experienced what we have, which is you end up being positive and a carrier even if you're asymptomatic, and other people may be sneezy, coughy, fevery, and have influenza type 1. Who knows, right? So we're assuming everybody is positive at this point. The other thing is that things just take so much longer. I don't know how detailed your institutions may be following and tracking your acute patients, especially thrombectomies, but we used to do very closely, we would follow all the AHA guidelines of trying to track our, DOI to groin times and things like that. And even though we still try and we still aspire to make those, I'm not sure it's working super well right now. Everything just takes a lot longer. I think also what we've learned is the devil's really in the details of everything, before, during, and after. It just seems like we've done it a million times for those of us that have been in practice for a while. But these small details really do matter. Again, on the comprehensive side of things, one thing I don't have up on the slide, it's really true, is that we're only as strong as our weakest link. And we forget, for those of us at large medical centers, oh, someone says the slides are not loading. Are you guys seeing the slides? Type in here. I just saw on the bottom. Is everybody seeing slides okay? Yeah.
It's Max.
Okay.
I see your slide.
Okay, good. All right. So it sounds like just a few. Okay. So just Rebecca, if you're on there, just try to reload it. I think it'll show up. But anyway, we're only as strong as our weakest links. For those of us that have medical students and rotating nurses and, fellows that may not be on our service but are, rotating through, I think those weak links really do have to be a part of these conversations, even though they're not normally a part of our team. Things like carrying pens around and, doing things that they shouldn't be normally doing, they wouldn't otherwise know. And so we do need to keep an eye out for that. And so I think those are kind of the things that we've been learning along the way. I changed my slide here. Just today, I want to talk a little bit about some of our data here. I live in King County. That's where Seattle is here in the state of Washington. As you guys may remember, I think we've been, at least from what we know now, Lord knows how these things end up, but from what we know now, on February 28th, we presented the first case, in the U.S., case 0. Since that time, we've had about 4,700 cases. This is from last night data, by the way, so a little day out of date. We've had 312 deaths since our first case was noted. We have a website, as most of you do in your areas. Sorry, this is a little bit blurry. We stopped recording the number of negative tests, so we're only showing positive tests. You can imagine, the first couple days we had a bajillion people coming in for tests, quite a few negatives, but we've stopped presenting those. If you look kind of middle of the way here on the right, you can see that both our deaths, and I'm sorry this isn't interactive, but on our website it is, both the deaths and the positive results kind of look the same, and they look hopefully to be flattening out just a little bit. I think there's some really interesting stuff that we end up starting to record, which is that, we haven't been doing autopsy testing on all of our patients, and we haven't been, all the patients that come in cardiac arrest and die, we're not testing everybody right away. So we do see these weird spikes every now and then, and that's just due to some of the challenges with testing that we have. And that's not unusual to us, but that just to point that out. Also on the left side of your screen, on the radiologic right, for those of you that do this every day, on the left side of your screen, you'll see that kind of in our area, this map might not look like much to you guys, but what we found is that in the most densely populated areas, obviously there's going to be more contact and more cases, but we've also have quite a few retirement communities here. And you may recall that we had a nursing home that kind of had a bit of a spike here, and a lot of the retirement communities, we get transfers in from there, people kind of higher density than you might expect in regular areas. And I don't think this is unusual, just a trend. On the very bottom, you can see in our area, some kind of COVID stuff that really does resonate, I think, generally, is that men seem to be a little more affected than women, both in just catching it and also having awful symptoms from it and dying from it. And also, the older you get, you seem to not fare as well. And if you have any morbidities, you're also kind of not in great shape. Just our status of today, and this is just our hospital data. I'm at Harborview Medical Center. We have 4 hospitals within our city here in Seattle that we work with, or 5 if you count the VA. We have the University of Washington Montlake campus, the University of Washington Northwest Hospital. We have Harborview Medical Center and Valley Medical Center, also Children's Hospital, but we don't really, they kind of keep to their own space and manage their own patients there. But we do have those hospitals immediately available. What makes our university a little bit unique, and I think Dr. Shapiro and Duckwiler have a similar thing, but we have this thing called the WWAMI system, which is that we manage at least the level 1 trauma and a lot of the other care for 5 surrounding states in Alaska, Wyoming, Idaho, and Montana. And so we do get a lot of transfers, and we've been dealing with, how to manage that. You can imagine cleaning out a medical transfer jet is a tricky proposition and exposes people in a lot of different ways. But here at Harborview, you can see our patient population there. We don't have the same ventilator challenge that most have. We do have ventilators available. We have some intubated patients with COVID. Yesterday, we did about 1,000 tests. We took about 1,000 tests and completed those. Our inpatient and ER turnaround is about 6.5 hours as of now. And we'll answer some of the questions you guys have about which tests we use, what they mean, all that kind of stuff. We'll go through that in a little bit. I think one of the things that I've seen is some of the ethical issues that are arising. And I do want to talk about this with my colleagues, and we'll open this up to a bit of a discussion. But I think we're sticking now to our guidelines. It's always tempting to try to do things on a case-by-case basis and be as compassionate as we possibly can. I think in the last couple of weeks it was a little more touch and go, and resources were a little more tight. And so, the patients with the dementia that are 93 years old that probably aren't a great candidate anyway, we may have tried. I think we've all had to really revisit the guidelines in our own consciousness and family discussions to figure out really what the right patient selection is. I think we get a lot of pushback about futility, and I think that's not new, but I think in a time of strained resources, you do have to really do some soul searching. And of course, time is brain, right? I talked a little bit about the door to groin times and things like that, where we're trying to really push to get vascular access and get up into the brain, but we really do need to be mindful that we're exposing many, many, many people along this path. And so it is a bit of an ethical issue, right? A balance between sort of time and life, and not just of the patient. And then, when's less more? We need to make sure that we have only the right amount of people exposed as possible to each patient. Let me try to get to the slide here. Sorry, once again, kind of click through, because I made these with the intention of doing this. An intubated patient is not always safer, and that's just because you have to make sure that you want to keep the circuit closed. You don't want any aerosolization of any of the cooties that might be inside of the tubes, right? And so the kind of 4 options that we think through are, okay, well, maybe we don't need to intubate the patient, or maybe we can intubate them in the ER. Do we want to intubate them on the angio table prior to a thrombectomy? Nope. Do we want to be really surprised and have to intubate these patients in the middle of the procedure? No, we really don't want to have to do that. And so we don't, Dr. Duckwiler was talking about their, an MRI facility first, and they've moved over to CT scan as it's faster. We don't routinely use MRI, we routinely use CT, but we are continuing to use our regular CT protocols, and I think we can talk about some of those radiology protocols if that's helpful. We do have a dedicated stroke room and a dedicated procedure room for COVID patients. We have 2 biplane angio suites. We have a hybrid OR for neurosurgical cases, and we use them for other things as well. It's a new room for us. We don't typically use the single plane for our interventions for brain, but we can if we have to. We try not to use them for COVID because the heart team is very, very busy. If you look at these numbers for us, I think that pre-COVID and current COVID, it's about the same. About 60% of our cases have been done awake and 2% interprocedural. We're trying to minimize doing that, as I said. Our ER has 5 negative pressure rooms, and so it's much, much easier for us to intubate in the emergency department, which is what we've been trying to do if we can, and I'm going to go over that here in just a second. So kind of ask ourselves the question, when do we intubate? And these are the criteria that I guess we would use probably always when we're doing it, but we're really revisiting this. Even if we're a tiny bit unsure, we're going to go ahead and intubate. And I would encourage you, I suspect it's similar for my colleagues, I would encourage you to take a look at this. If you disagree with it, for sure we can talk about it. But I think these are pretty general and cover most of the conditions that all of us would agree. Safer to intubate anyway, but probably safer to think through intubation before the procedure so you don't have to break scrub and do all that stuff to get it done. I was just talking about some of these details. If needed, we're trying to do it in the emergency room, primarily because we do have negative pressure rooms, and some of you have asked questions on the, on the right side of the screen here about negative pressure rooms. Our angio suites are not negative pressure, So we prefer to do it intubation outside if we can. We do it after CT in the emergency department and prior to transport. As you can imagine, this is that whole time is brain thing because it does add a whole lot of time. Our ED attendings are qualified and suitable and wonderful to intubate. We have anesthesia backup if required. And we do all of this, again, just being mindful of the PPEs that we have available for people. We do leave the patient on the portable ventilator all the way through their entire visit to our thrombectomy world and our acute procedures, from the ER down to the angio suite up to the ICU, and that's just primarily to minimize the amount of times that anybody would have exposure. We use extra long extension tubing, which can be really annoying, but we think that that's the safest way to make sure that we don't have to accidentally, extubate a patient or break any of the circuit. During angio, there's a couple things that I want to talk through. We have a door between our rooms, and so we are trying, the door between where the control room is, where the techs sit, and the angio suite. Obviously, there's doors that shield the room, but we need that door to stay closed. And so what we're trying to do is keep the control room and the angio suite separate. We also try to plan our teams whenever we have a procedure to think about all of the devices and things that we're going to need beforehand so that those can be pulled so that we're not digging around in supplies, asking a lot of questions, taking time. But we've moved our supply carts outside of our room so that we don't accidentally, open one of the doors and get something on them. So those now sit out there, and that is helpful, like I said, to just plan your supplies beforehand. We try not to have people leaving the room. I know that anesthesia shifts change. We have CRNAs and residents and fellows and stuff that need to come and go. We also try to minimize the staff in the room. I try to have one fellow with me, so it's one attending, one fellow as best we can. I know we're in a learning institution, but trying to do that. I'm going to show you a picture here in a second of what this all looks like. We do have a warm zone. We use two-way radio communication between us so that we don't have to misunderstand or mishear each other. Here's our photograph of our team. So I want to show you, and it's hilarious, all the words that come up. I had never heard of doffing before all of this. I didn't even know what that was. I'd heard of donning, but it sounded very British to me. I had never quite used it. But that circled picture right there is our DOFficer. And our DOFficer is present for all of our procedures. You see this she helps get us all set up for the rooms here. We have all of our equipment, that's our little square that we all stand in to make sure that's our hot zone, to make sure that once you're in there, the DOFficer can help you observe on and off donning and doffing. All supplies are kept, like I said, outside of the room. Our N95, we'll talk about PPEs. The question that comes up a lot is, well, what PPEs do we use during thrombectomy? Everything is in short supply, and we don't know. We're going to talk a little bit about what some of those are after. I'll let my colleagues explain their views of that as well. The short answer is we really just don't know. I mean, the important aspects to all this is just have real mindfulness, that airborne precautions for everyone no matter what. We've said that if there's no recent aerosolizing event, less than 15 minutes, droplet precautions and everything should be safe. I think that in the past 2-3 days, that's been up to 30 minutes instead of 15, and this whole thing about probably safe is kind of going away now too. So this may be a moot point as far as our policy goes here at Harborview as of now. If there is risk for aerosolizing, the airborne precautions, N95 and all that, is still going to be required. The reuse of N95s, as discussed by Dr. Duckwiler, is tricky. We've all been fitted and assigned our own N95s, and we kind of carry those around with us and keep them as clean and safe as we can. The anesthesia teams also have their own and different PPEs. This is Dr. Mike Levitt, my colleague, scrubbed in with one of our fellows. You can see the rooms, kind of what they look like. On the far left, you can see, I'll take my little arrow if you can see that, but that cart is now not in the room. It was when we started. You can see that he's using a jet, so he's probably doing the adapt technique in there for a stroke. But this is all of our equipment. You can see we've got anesthesia. Normally, these screens that normally serve to protect you from the radiation are also kind of a good blocker for stuff. Not great, but a good blocker for some of these things. And you can see he's in full gear. This is kind of what our room looks like. We've now removed, you can see the gloves here in the foreground. We've now removed everything from our room. It looks like a ghost town in there now, but this was kind of week 1 or 2 when we were just getting started with our supplies. So after angio, usually we get a Dualenergy CT on our patients. And the reason we get a Dualenergy CT, for those of you who do it or don't, is so we can tell the difference between what's contrast and what's blood in any case that we're concerned about it. But we're no longer doing that. So a couple things. We don't extubate unless the angio suite is a negative pressure room. Ours is not. So we don't do it, and we recommend doing it upstairs in the ICU, and that's where patients go until we can confirm that they're not. As I said, we try to use a flat panel CT and angio. We use an expert CT, but whatever kind of flat panel you can use can be really helpful so that you don't have to go back, contaminate a new room, more resources, more donning and doffing. Typically, as my colleagues have said, we say 1 hour after the room has been cleaned post-procedure. It's about an hour before we can use all of that. A couple things, we'll talk about this probably in more detail, at least for me, that we think about after angio. We think about the cleanliness and how to get patients here and there, and the part that we forget is our human side and how scared and terrified the patients' families are. They're no longer in the waiting room. We don't have any visitors, as most hospitals don't. People are scared. They want to know outcomes, and the phone isn't quite enough. For those of you that aren't aware, the federal government has kind of relaxed our HIPAA regulations a little bit during COVID and allowed us to use some of these patient communication tools that normally are not allowed by us. And so I've tried my best to think about using FaceTime and other things to communicate so that a doctor can see my face and whatever. I know getting a telemedicine call in clinic is a different deal, but sort of after a case, you don't have all those options all the time. So I would think about the patient and their family after the angio as well, not just the bugs that we're working against and all the procedures. What we wish we did earlier, I mean, I guess I would say, and my colleagues would probably say, the short answer is probably everything. Some of the things that I would say, maybe do a dry run. If you haven't had a lot of COVID cases in your area, you haven't been concerned about this too much, you might try doing a dry run of just what you would do and see how you might make some quick changes. I think we would engage with our team leaders earlier and get these protocols together. As I said, the administrative side of this has often been harder. I think Dr. Duckwiler's had to work against unions trying to get these things done, so it's bigger than your team in your hospital. It may be involving unions in other places as well. So think about that as early and as often as you can. All those folks stopping elective cases and really being honest about what's elective and what's not. I'd say a couple things I don't have on this is the staff tracking part that we just started maybe 10 days ago or so, having all of our staff kind of sign a book in the morning about symptom reporting. Do you have XYZ symptoms? Can you swear on that kind of thing? So I think we should have done that probably sooner. Also sort of minimizing the number of humans that come in and out of our rooms and have contact with our patients, and also requiring fitting of N95 and PPE, just requiring it. Like if you're in our hospital and you're working here, you have to be fitted. You have to know your size. Otherwise, if you're a size small and you're wearing a size medium mask, it's like not having a mask at all, and it's wasting PPE. So really requiring fitting. We have on our badges, we have a little size that says what our PPE sizing is and a little serial number for the PPE that we've been given. So I think, tracking that is good. Finally, I think the thing that I would say I wish we had done earlier was just really not underestimate the emotional burden that everything is requiring, not just to us as doctors, but to everybody in the hospital and to patients and their families. It really does take a whole lot more to think through these cases than it normally would, and I would encourage everybody to think through that. Super real, because we're all still very human and we forget that sometimes. So I wish all of you luck. Here's some, funny pictures that may not be so funny anymore. These are just taken from Google and things that we've seen. I saw a guy in a scuba suit, no kidding, at the grocery store. I live in Seattle, at Metropolitan Market. A guy was in a scuba outfit. I'm not sure what that means. But thank you. I'm Melanie Walker. My email is actually walkerm@uw.edu. The M should be in there. And my colleague Michael Levitt has also been very instrumental in helping getting some of these procedures and processes through the door. So thank you for your time. I'm sorry I went a couple minutes too long. I want to try to get some questions started with my colleagues here. The first question that came up, I think, was for Dr. Duckwiler, and one of the participants wanted to know if you may be willing to share some of your flow charts so we can coordinate with the Medtronic team and offer some of those. Many of those may be available online too. But maybe I can turn it over to Dr. Duckwiler, since you brought up PPE types 1 and 2. Maybe you can describe PPE types 1 and 2 and what those mean, and then Max, if you want to tag on what it means at your institution.
Right. So number one, yeah. So I think that maybe Medtronic has a copy of those slides, so they could just share those. In terms of PPE 1 and 2, so level 1 is what we would consider our standard outfits in the angio suite. So it's technically it's a gown, a surgical mask, and eye protection, either face shield or goggles. So when we're talking about doing these cases, just our standard surgical outfit when we go in and do a case. For PPE 2, we have to worry about small particles. Level 1 is really droplet contamination, so if a drop hits your mask, it's not going to get inside. You're good. But small particles, viral particles going through the mask, well, now we need something that can stop that. So the most commonly used devices are a N95 mask, which has to be fitted, so there's air leak, and so the air has to go through the mask, and the air in the mask could hopefully stop aerosolized particles. The other thing is the paper suits, which is basically a face shield and hood with a HEPA filter, so that you're going diving. You got your own air supply, and everything should be held in abeyance to get to your face because of the face shield and the filtered air. So when we go in to do a patient who is questionable or COVID positive, then I would don an N95 mask. I'd put a surgical mask over that, and then protection of my face shield or goggles, even better. And of course, our standard surgical wear. And also typically wear the long boot covers so that so I don't leave anything exposed. So that would be my personal garb during a COVID uncertain case. Always good to test these things out first, because the last thing you want is to be in there and have all this stuff on, and then you can't see anything because your goggles have fogged up. So these things are uncomfortable, hard to do. Fogging up is a problem. You need to have these things in place and know what to do and how to put them on. And like I said, I think when you're covered like that, you're pretty well protected in a procedure. When you're not protected in a procedure is when you take all that stuff off. So if you're not taking it off right, you grab the front of the mask, you are not washing your hands in between steps when you're touching some of your outer gear, you're not taking off your gown appropriately, or somebody else is not doing that. That's, I think, the real risky period. So not only having the material on, having the right material on, but taking it off is critical.
And just the stuff I would quick add on is take stuff out of your pockets. Don't wear a watch. Now's not the time for jewelry, that kind of stuff. Like, just minimize everything that can possibly have, some sort of contact with anything on it. Max, do you have anything to add?
No, not really. I think we pretty much do what you do in terms of protection. We try as much as possible to wear an N95 in the procedure room. If you have it, just wear it. You never know when that COVID unknown patient is going to turn up COVID positive in the middle of your procedure. We've had that happen a few times. The tests come back relatively quickly, and something like that might happen. Who knows? We obviously are learning so much. Who knows how much protection this or that thing offers? You put a mask on the patient, what does that do? Negative, positive pressure room, again, that's not really for if you're in the room, whether it's positive or negative pressure, probably having negative pressure actually exposes you a little bit more. So negative pressure is more to just keep the outside clean. But I think most places don't have a negative pressure room. It's just that we happen to have, and at Bellevue at our hospital, at the city hospital, it's a positive pressure room. There was a question, I think, jumping ahead. Someone asked the question that Robert was saying, right? My institution informed us that no operating room. So basically, there's a regulatory issue at one of the institutions that an OR cannot be a negative pressure room. How did we manage to do that? I'm sorry, I don't have the answer to that question. But maybe the guidelines differ between states or institutions. We have, other than our biplane suite, we have a couple of other negative pressure OR rooms that are being used for, open surgical purposes when necessary for COVID patients. Most people, again, most rooms are positive pressure, and you just have to kind of be aware of that.
Yeah. So I will keep an eye on whether or not there's follow-up questions to what we've just been talking about, but we're going to move on to the next question, and I can start out answering this one, and we can discuss it. And the question is really around COVID testing, which ones are being used or not. There's two basic types of tests. There's the molecular testing and the serological testing, and the molecular testing is based more on the nucleic acids, the RNA, DNA stuff. Those are done primarily by nasopharyngeal swabs. There are some salivary tests as well. And those are, many of you have either seen them or had them. They can take up to a couple of hours to be done. Some places are doing them even more quickly. Supposedly there's a 5-minute version made by Abbott. We have not seen those. It's usually a couple of hours done, and those again are the molecular side. The serological side, there was one test approved, I think April 1st. There's a couple of different ones. The serological blood tests that aren't taken from nasopharyngeal or saliva stuff, but from blood, have a couple different things that can be looked at in them. The reason those are tricky is you can look for neutralizing antibodies or ELISA or however whatever type and way that you're looking for things. The problem is that nobody has really figured out exactly what immunity means and when you develop antibodies and what those mean and how quickly you get them and what comes and goes. There's many studies going on, and you'll start to see more of those, primarily because there's a huge interest not just in people getting better and in documenting that and getting back to work, but also an opportunity to use convalescent serum to help take the antibodies from people who have recovered and give that to sick people. But those are all still sort of all over the map. So I'd focus, for those of you in practice doing this every day, I'd focus more on the meaning of the molecular ones and understand a little bit more about the nasopharyngeal swabs and the salivary ones. The nasopharyngeal ones, I swear it's like we joke and say it's kind of like having when we do a transsphenoidal pituitary surgery, right? Because you really have to get it way up in there. It feels like a biopsy of your brain, but you do need to do that to get a good sample. So those are the ones that we're using. I suspect I'll ask my two colleagues if they're doing anything differently.
No, it's the same. I think most of it, as I'm sure you know, just in the news, like today, over the past couple of days, you see what's going on in the news in terms of antibody testing. A work in progress, right, is what they call it. So it's basically just PCR, nasal swab. Yeah, as you mentioned, Melanie, nothing like a personal experience with a nasal swab to know what that feels like.
True.
So, but it is like they're doing their, like if you're, for those of you that have gone through it, that's what it takes. Like if you look at those 20-30% false negatives, like, well, the better you swab, the less of those you're going to get. But they do come back pretty fast too for us. Maybe 2 to 6 hours is what it generally takes. Not to say, I think we just happen to be like a little bit blessed in our institutions with how things are. Like, if you look at what's going on in the boroughs of New York, like if you look at the spectrum of the hospitals, it's heartbreaking, the differences that exist on every level. So to the extent that we can continue to offer our services again, like what we can do, we should do, because not everybody can do it.
In terms of just for other interventions, not just strokes, like we try to draw a sample, prior to as we're getting ready to go into our procedure for stroke patients. But for those of you doing other emergent type procedures that aren't strokes, that may have follow-on procedures. So for example, some of you may be doing preoperative embolizations for, tumor spines or brains or whatever. Some of you may be doing AVM cases that will go to surgical resection that have bled, something like that. We try to get, sometimes we know because the patient's been an inpatient and we know their status, but we try to get the test before we do our procedure if we don't know the answer. And at our facility anyway, you have to have a COVID test within 72 hours to know. So if they're going to go to the OR soon, you probably think about doing that for your colleagues just because of the amount of time it takes. But all procedures need to have, at least the test is valid only for 72 hours, right? So our interpretation of it is.
That's right. The only thing it means that there is virus in the nose, right? At the time when they swabbed it.
Exactly.
The other thing I just wanted to tag on that kind of brings me back to like my residency days when we had a really old-time neurologist from many years ago, and he said, the most important neurologic test is a chest X-ray. This was like back like 15 years ago. It's like, if you're not sure, get a chest X-ray before COVID, before anything else. Because oftentimes the answer would be there. And as many of you know, the CAT scans are sometimes more sensitive than the PCRs, as you probably are aware. So one of the things that we routinely get into is, looking at chest X-rays if they're available. If somebody is a stroke code and they get a CTA, do spend a second looking at those like lung apices or whatever lungs you have in the view. Sometimes that tells you the whole story, because the way the lungs look, once you've seen a couple of them, you know what the lungs of the COVID people look like. So there's a lot of information.
There's a question in here. There's a question further down that really is about that, saying, should we be doing screening chest X-rays or screening CTs as we're getting the workup for our stroke patients? And what are your views on that, both of you?
Well, everybody gets a CT scan before a procedure, right? That's like required.
Sorry, I meant of chest. That people were asking about chest.
I'm sorry. So the question is, should everybody get a chest X-ray before?
Yeah, like a screening. I think one of the questions came in saying if you're already getting you're doing your head workup, you're getting a head CT, CTA, whatever you're doing at your facility, and hasn't been done elsewhere and is being repeated or whatever, should we be getting a screening chest X-ray? Or if you're already doing a CTA, should you look in the chest if you're concerned? I mean, what's your threshold for doing more than just the brain when you're doing your stroke workup?
Yeah, no, it's we haven't. I know there were some reports from people in China who would do the head and then also do the chest just to see. So when they're having their CT, I think that's a little excessive. But if you're doing a long segment CTA that includes the arch, it's not so hard then to change the windows and look at the upper lungs, although this is more of a lower lung phenomenon. So at UCLA, we have a reporting classification that, we typical, indeterminate, atypical, or negative. So, if they fall into the negative category, then, they may be in the early stage of disease, but they certainly are not likely to be in the late stages of disease. So that might be somewhat helpful, but I think that's really about the test.
Max, how do you feel about that?
I think it's a great question that has come up a few times. Like, why not just, after you've done your CTA, just go through those lungs on the way down, like look at everything. We don't have a protocol for that. More often than not, we do have access to a chest X-ray. Again, it's not part of your standard stroke protocol, but generally we've been trying to get those if there's a question. Of course, everybody's assumed to be COVID positive. That's the workflow. If you're not sure, just assume that they're positive. But we don't have a standard chest CT rundown, but in my experience, just looking like depending on how you do what protocol you have in your institution for CTA. If your CTA covers the aortic, kind of like the top of the arch, you get to see like 30, maybe 40% of the lungs. And as Gary said, yes, of course, there's a lot of it could be at the bases, but when it's when the COVID's active, oftentimes it's everywhere, and you get to see some of that up there too. And of course, that's not confirmation that they're positive. It's just that you a little bit more know what you're dealing with.
Yeah, I'd say our threshold here at Harborview is, normally I wouldn't, and normally I don't think that we would do it on every patient even now, but I think people get, if the ambulance driver hears from the family that this person had a cough like 30 hours ago, there's a much, much lower threshold to be suspicious. And so if they are in there, we have had a couple patients that have had a chest CT along with or a chest X-ray that we normally would not have gotten. So I think to answer that, and maybe going along with this, there's been a couple questions about patient selection and use of resources. And I think the way that it was phrased is, what do you do with an elderly, intubated, known COVID patient that has an LVO? Would you take them for thrombectomy or not? I wonder what my two colleagues might say. Max, what do you think?
So I think, again, in terms of, to answer the question, what happens if the patient is COVID positive and has very serious disease? In my discussions with our kind of stroke neurology colleagues and in what I'm seeing on the floors, just firsthand doing family outreach that we do, a lot of times these decisions are made for us. They may not even call us. Like, as much as we might be struggling with what exactly is the right thing to do, the medical team oftentimes will say, okay, like what we're going to do, or the stroke team may not call us for a thrombectomy because they don't think it makes sense to call for it. I mean, it's a difficult situation. A lot of these patients, as we speak to, they're sick. They don't have a collateral reserve poor because they don't have enough oxygen in the blood. They don't have enough blood pressure to push through the collateral. So the outcomes can be, again, like the glass is 1/10 full. Like, you have to be ready. Your number needed to treat approach needs to factor in the COVID for that. But generally, our general model, like if you ask, like, what's the answer to the question? Our general model is, if we are called for a thrombectomy and someone has made a decision, and that someone would be a clinical stroke neurologist or someone who is a neurology evaluation has been done and a decision was made to offer the possibility of thrombectomy, and we don't like to refuse them. So we will do the vast majority of these patients. We're generally not the ones to say no if someone thinks we might be helpful.
Dr. Duckwiler, how do you feel?
Yeah, I would agree. I would just categorize this as another factor in judging potential outcomes. So if you have a patient in their scan and you think that they have 82 cc's of core tissue, are you going to go? Maybe not. Okay, so they have they have already an established extensive infarct, maybe not that much, maybe 65 cc's, but they have an ejection fraction of 10, and it's been 7 hours since their onset of stroke. You would say, well, analysis of that is not so good. So depending upon their prognosis, if they've been intubated for a while for COVID, the likelihood of getting out of that state is, at least as far as we know so far, not great. And so it becomes an assessment like any other of these medical factors we do. And that's how I would view it. I wouldn't refuse doing a patient, and I agree with Max that we tend to cast the net wider rather than exclude patients. We'd prefer not to exclude patients if we don't have really good reasons to, but I would just assess that along with the other health factors we normally do.
Right on. I agree, and well said by both of you. The next question was really around the negative pressure operating rooms, and I think Max and I both don't know. I don't know the answer to the specific either state or regional policy that one of you is referring to. Dr. Duckwiler, do you know if there's any sort of regulation about not being able to work? At least here, we don't. Our angio suites are not negative pressure, or not positive. We don't have a regulation not allowing us to do it, but.
Yeah, I'm not aware of any regulation. When we built our hospital, all the rooms were built as sort of modular. So the ORs and the procedure rooms and the cardiology rooms were all built so that they could be reconfigured to interventional suites, or they could be reconfigured to OR suites. So I assume it is not the basic structure of the room, because they, pretty much like OR rooms, they have the doors, and it's just that our rooms are leaded and fewer rooms in the OR are leaded. So I assume that the air and all that has been put in place. I just don't think that they operate it at this point, or they haven't activated and gotten approval for converting them to negative pressure rooms.
Mm-hmm. Yeah, that's probably true, but I'm sorry that I don't in our experience, but that sounds right to me too. There's another question that's interesting, and no one's going to have the right answer, but maybe just commiserating, is that all of these changes that we've now made in our angio suites and hospitals and policies and even dealing directly with patients, do those become best practice in the future, and when do they reverse back to what we thought or what we used to do? Or what's our threshold to really reduce all of these safeguards for everybody? And I wonder what that threshold is if we say, okay, no COVID patients for 60 days, and then we can take this thing away or stop using PPE for this or that. I really don't know, and I've thought about that a lot. Like, what's it going to take to get us back to not having to be in spacesuits every time we go into our suites? But maybe Max and Dr. Duckwiler have thought about this a little bit too.
I think like you said, one of the great areas of interest is this antibody test and whether the antibodies actually do confer some resistance to reinfection. If that occurs, then that would be extremely helpful in moving forward and understanding what we can do and what we'd have to do in a procedure, whether it's some short-term immunity, whether it's long-term immunity. There's a lot of information that's just not available yet. But I think that a lot of the processes we have for infection control, I'll be very honest, in intravascular procedures, in relatively, non-immunocompromised people, your infection rates are going to be really low, okay? They just are, unless you're picking your nose right before you go in and you're wearing appropriate gear and you're putting it on appropriately. It's very low. I had a mentor who used to say, yeah, interventional is a clean procedure. It's not a sterile procedure. So I think instituting some of these things are going to be helpful there. But really, the big benefit here is crisis management, and that's top to bottom. So we see that how Taiwan is doing. They had infrastructure policies, group involved. So even before they had the first case, they were on top of that, and that's why they've done so well, being, they're basically an extension of mainland China. So some of those things will prepare us for the next event, because we know there will be a next event, and I think that's the primary benefit coming from this is in that disaster planning when this occurs again.
One of the things that I hope stays, one of you asked a question about best practices from all this, is that people will stay home when they're sick, like forever. I hope that we always do that. And I've noticed over the years, even me, when I was a resident or a fellow, you kind of maybe have a flu, you end up having to go to work. Like, really, this is a really good public health hygiene thing, is don't come to work if you're sick. And it may be legal for us to do that now, and maybe that'll change. But I do think that should be a best practice that we should stick to. Let's see. So another question is about we talked a little bit about triaging and patient selection. The other is about volumes. I mean, I can say from my end, we do about a lot of cases a year, but as far as thrombectomies, we probably do 250 at Harborview per year, so about 20 a month. We only did 5 thrombectomies last month, so we've had a significant decrease. And kind of anecdotal, some of my colleagues at the nearby facilities that are thrombectomy capable, patients and ambulance drivers are like, whoa, Harborview's got all the COVID. We're going to go to the other institution for now. And so I think there's some degree of diversion just because of awareness. But I don't think that the number of strokes has decreased at all. I know nationally they're saying there has, but at least our volume has gone down because of patients going elsewhere out of concern for catching something at our institution. But I don't know, if my colleagues, if you've had the same experience.
I think some patients have stayed home. Yeah, I do.
I mean, we have for sure seen a drop in non-COVID through the door strokes. That's across the board, and I can tell that for not just for our institution, but just across New York City. And of course, we are like everyone. It's not like you can pick a non-COVID place these days to take a thrombectomy patient to. That all these big hospitals are going to be filled with COVID, and so. But I think it's very real. I think with the collateral damage from this, and in the news there is decline in STEMI treatments. Like, I think the collateral damage from this is very hard to estimate, but it's very, very real. We've seen an uptrend, as I think I mentioned, in the COVID patients because of this hypercoagulable state. That's what we've seen most, in the past months. That's what we're seeing. We're seeing arterial occlusions. We're seeing venous thromboses, which we don't see as much. We see relatively little of that. generally, but we've seen an uptick in those as well.
Yeah, that's
How about
another question
yeah.
that someone had asked about was the types of strokes that if any of us have been seeing a change, more sinus thrombosis as opposed to arterial thrombosis. It sounds like, Max, that's been the case for you at least.
It has been, yeah, for me and for some of our colleagues across the city. We've seen that. I wish I could tell you the outcomes are good, and it's all very anecdotal, but it's just, I think when it comes on background of bad COVID, it's not great. But, at least it's not always like this. Sometimes, again, anecdotally, there are these patients that kind of are recovering, so they don't have a bad pulmonary COVID, but there's a pro-inflammatory stage, if we believe in that can come sort of at the tail end of any viral infection probably, that increases coagulability. And so these are patients that are, from a pulmonary perspective, very salvageable. And these are the ones we need, I think we can make a difference there.
One of our participants asked a kind of related question about this. You were talking about the procoagulant state, about has our practice with TPA changed at all with this? And I think, in fact, TPA is probably super helpful. People have even been experimenting in some trials with it for COVID patients, but my practice hasn't changed beyond the guidelines for TPA at all in our stroke patients. How about for you guys?
It's the same for us. No change.
Yeah. Same.
Yeah, I don't think we use it any more or less. I don't know, the stroke neurologists who are the first to hear about patients may have a better answer for that, but at least by the time they get to us, our practice has probably not changed at all. A really interesting question about anything that we've heard or experienced about the neurological differences in patients with COVID or some of the symptoms for COVID. And I just say it can get a little bit confusing because when you don't get oxygen into your brain because your lungs aren't working very well, you're going to have some weird symptoms that may or may not be primary brain symptoms, but may be more referable to, your underlying state to be able to oxygenate things. But I think the more we start to look at patients as in the convalescent state, people that have recovered and whatever, maybe we'll see some weird neurologic deficits. But the one thing that does seem to be a little more prevalent is bleeding in the brain. But I think those are just from reports, retrospective reports from the Chinese literature. But maybe Max and Dr. Duckwiler would have other experiences on neurologic symptoms in COVID patients.
No, there are a lot of reports of a variety of things, but I think we have to wait and see. We need more numbers to really know what's going on.
Max, what do you think?
No, I agree. I think anecdotally, we can, there are pictures going around of this or that kind of bleed or something like that. And I do believe that ultimately this will pan out to be a real increase in numbers from whatever mechanism, but it's really hard to know.
Yeah, I think
there's so much unknown, right?
You just get so overwhelmed. For those of you that hang out in the ICU or have worked in the ICUs before, you just get so overwhelmed with the other systemic problems that these are comatose patients. It's not like you're going to get a neuro exam, right? And even when they come in, they're coughing and short of breath. You're not going to, get reflexes and stuff. So, you might if you're a really good spare time, whatever in your team, but chances are you're focused more on resuscitation and getting these patients together than a neuro exam. So I think, as we're all saying, maybe as things kind of level out and we get people getting recovered and people getting less terrible cases of the disease, we may be able to see what these procoagulant states may do in the future. I guess the last question. The last question that's come. Oh, go ahead, Matt.
No, I just wanted to, quickly touch base on generally one of the things that, going back to resource availability, one of the major changes in the workflow that we've witnessed across the board is just people are not getting as many scans as often as you would like, right? How often are you going to take that COVID patient back for another CAT scan and so forth? So that's data. We need more data, and we don't have that. I think, Melanie, you mentioned autopsy, right? We have so few autopsies on our end as well. We have a hospital that's just begging people, please talk about autopsies with relatives. We just are not learning as much as we can.
That's true. I've had, families are just not wanting to have autopsies. They know that there's COVID and they don't want to know more. And so I think that there's not as many as we'd like to see, for sure, at least here. So I guess our the last question, or the last category of questions, is really around staff exposures and the doctors that may be symptomatic or whatever. And I would say from our perspective, kind of two ways to think about it. One is people who show up at work with symptoms, and the other people who are accidentally exposed to patients who are either have COVID or suspected of having COVID. And I think those are two kind of different categories. If you have symptoms, it's hard to know where you developed them. Usually we can track that, but maybe not. We do for staff, we do every morning reporting of symptoms, so we know. If you have symptoms, you are sent home. You're given a test and you're sent home. You need to be symptom-free to work. I can't come back to work until that test returns negative. If you've been exposed, kind of same thing. If you're asymptomatic, you get to keep working during your exposure. If you are symptomatic during your exposure, you have to go home. Either way, you're going to get tested, and you can't return to work until you are negative and symptom-free. So that's what it is from our perspective, but Max and Dr. Duckwiler will have to give theirs.
That's very similar to, thankfully we have test availability. That obviously wasn't the case early on, but at least now there's a way to get tested. And so I hope you're right, Melanie. I hope people will stay home if, when they're sick. We just have such a workaholic culture in general, but it's one of the things that I think is just going to have to change for a long time, along with many others.
Yeah, I agree. There are other things that, in terms of the testing and in terms of exposure, it's very similar. But I find myself walking around, and because we are not doing elective cases, sometimes our techs and our techs and nurses are sitting around. I just go, yeah, I don't think that's 6 feet, guys. I don't think that's 6 feet, right? So there is this natural tendency, I think, of people in the situation, to revert back to normal activities, and this is what they're used to doing here. So you do have to remind people that there is real possibility of transmission. You got to be careful about what you touch, where you go, how close you are to people. So I do find myself when I'm in the hospital sort of reminding people there, because it's not just protecting them, it's protecting their families, protecting other people and other staff. So maybe they hate me a little bit for being so rules-based, but I think it's people, they follow if somebody leads.
It's true. Yeah, and sometimes just need a good reminder. It's so easy to fall back onto what we did, so like a month ago. It just feels natural to all of us, and we all have to remember these are new times, and so these changes are important. The one last thing that I would say that I forgot to mention earlier is that we often forget to wear shoe covers, and then we wear our shoes home and into our cars and do all these things, right? And so I don't know what's on the floor just generally, but just think through that, especially in the intervention suite, and if you're bouncing around in the ICUs and stuff, that shoe covers are very helpful. Those are my
I have a different pair of shoes at work. So I have in my office, which is luckily close to the angio suite, I go to the whatever that scrub machine is. I get new scrubs. I put them in my office. I take the scrubs. Anything I wear, once I get to the hospital, I change it into what I'm going to work in, and then I change back and get a new set. I have a totally different pair of shoes. I go to the house, I go home, my shoes stay at the front door. I'm really wearing only one pair of shoes out. Small things like this probably do make a difference.
Well, I think those are all of our questions, and I think I've fully expressed anything that I can be helpful with. Max, do you have any final comments or thoughts for the group?
No, I just want to thank Medtronic for organizing this. I think it's, anything we can do to help educate and to, anything we can do to help. And many times, again, I guess I feel that for me, maybe I'm saying this too often, like we're a relatively small part of this huge picture. And probably one of the best things we can do is to stay available for the patients that need us, especially the COVID negative problem for me. Like the drop in the COVID negative strokes for me is very real. I hope these patients are going somewhere, but I don't know where they're going. And that's a public, it's a bigger picture in terms of access to healthcare, but that's always what we've tried to do, is to be there for the ones that need us. That's what we can do.
Dr. Duckwiler, any final comments or thoughts?
Just stay safe, stay healthy.
Well, thank you, everybody, for joining, and thank you to Medtronic. We're going to turn it back over to our moderator.
Thank you, Melanie. Thank you so much.
All right. Thank you. Thank you to all of our speakers today. If there are any comments or questions regarding this program, please direct them to rs.nvoma@medtronic.com. Please remember, any off-label questions should be directed to rs.nvoma@medtronic.com as well. Thank you for your time and participation. This concludes today's webinar. Thank you.